an immune-mediated disease. As the longtime chief of the NIAID Laboratory of Immunoregulation, Dr. Fauci has made many seminal contributions in basic and clinical research and is one of the world's most cited biomedical scientists. He was one of the principal architects of the President's Emergency Plan for AIDS Relief, or PEPFAR, a program that has saved millions of lives through the developing world. Thank you for joining us today, Dr. Fauci.
Warm greetings, everyone. This is Tony Fauci here at the National Institutes of Health, and it is truly a great privilege to address the 2022 National Ryan White Conference on HIV care and treatment. As you can see from this first slide, I'm going to be talking about where we are in 2022 and where we are going in the coming years with a particular viewpoint from NIAID. Let's take a look at where we are with regard to the recent global statistics that came out from UNAIDS just about a month ago. As you can see, in 2021, there are about 38 million people living with HIV, but unfortunately, still 1.5 million newly infected individuals with 650,000 deaths. Since the beginning of the pandemic, over 40 million people have died from AIDS. In the United States, we still have a serious problem that we've become somewhat inured to. There are 1.2 million people living with HIV, and sadly, 13% of them are unaware of their infection. We've had over 780,000 deaths, and again, something that is very disturbing is that 31,000 people are newly diagnosed with HIV in 2020, and most of them were very young people with a disparate amount among men who have sex with men and brown and black people. I'm going to mention the impact, and I'll get back to that later in the talk, on COVID-19, on HIV/AIDS, and it really has been a negative impact. For example, the diagnoses of HIV decreased and fewer HIV-positive people started ART in 40 of 50 countries in 2020. Harm reduction services for people who use drugs were disrupted in 2/3 of the 130 countries in 2020. And importantly, there was reduced access to TB diagnosis and treatment, resulting, unfortunately, in an increase in TB deaths among persons with HIV in 2020 compared to 2019. So the disruption on the social order has had a negative impact on our efforts in HIV/AIDS. Now, recently, in the end of July, the beginning of August, we had the 24th International AIDS Conference in Montreal, which was hybrid, both in person and virtually. And with that, we were able to, about 6 months before then, put out our national HIV/AIDS strategy. And as President Biden said in a statement in that strategy, it is a plan to make sure that the latest advances in HIV prevention, diagnosis, and treatment are available to everyone, regardless of their age, race, gender, identity, sexual orientation, disability, or other factors. And getting back to the International AIDS Conference that I mentioned a moment ago, this was a theme that was a recurring theme, namely re-engaging, following the science, and make sure that we have equity. I'm very happy again to recognize the recent appointment of my colleague and friend John Nkengasong as the new U.S. Global AIDS Coordinator in charge of the PEPFAR program. So let's take a moment to review some of the results of PEPFAR, which we should all be very proud of. 21 million lives saved, 2.8 million uninfected children born to mothers who were living with HIV, 19 million people on ART in 2021, and 1 million people newly enrolled on PrEP in 2021, and almost 3 million adolescent girls and young women were reached with comprehensive HIV prevention services in 2021. We all must not forget that we must stay on course for ending the HIV epidemic plan for America. in which there would be hopefully 75% reduction in new cases in 5 years and 90% reduction in 10 years. We are not on course, and we've got to get back on course with this ambitious plan to end the epidemic within 10 years. Funding the epidemic and ending the epidemic has increased dramatically. And fortunately, over the last couple of years, after a flat amount of budget for HIV/AIDS, we've increased significantly, as shown on the slide, going from 2019 through 2022. And importantly, in 2023, the presidential budget request is now $850 million for ending the epidemic program. NIH, particularly NIAID, supports the EHE, which, as you know, stands for Ending HIV Epidemic, supports those goals predominantly by implementation research. And as shown in the July issue of a JADE supplement with about 30 articles on these projects, as you can see from the map on the right-hand part of the slide, there are a number of programs, particularly the CFARs, or the Centers for AIDS Research, as well as a number of other programs that are specifically aimed at ending the HIV. I want to divide the rest of my talk into two major components about HIV now and in the years to come. One is closing the implementation gaps, and the other is developing and delivering new and improved treatment and prevention. So let's start off with closing the implementation gaps. We know and have benefited greatly from highly effective antiretroviral therapy for HIV, which is, in my mind, in the mind of so many, truly one of the most important biomedical research advances of our era. The ART, or ART, medicine cabinet now is full with combination medicines, a number of vulnerable targets in the HIV replication cycle, which has led to a complete transformation of the lives of individuals living with HIV. When I first began taking care of persons with HIV before we knew it was HIV, in the early 80s, from the time of diagnosis to the time of death was about 1 to 2 years. Today, if a young person in their mid to late 20s who's living with HIV gets started on ART in a timely fashion, one can predict a lifespan of over 50 years, which makes it almost a normal lifespan. Globally, with PEPFAR and the Global Fund, we're seeing the same thing. As treatment coverage, as shown in the blue bars, increases, AIDS-related deaths of all ages decreases dramatically. However, as I mentioned on the slide a few moments ago, a number of implementation gaps exist that must be addressed. Testing, retention, and viral suppression with antiretroviral therapy, management of comorbidities, harm reduction, food, housing, and security, and of course, human rights, including the ever-present problem with stigma and discrimination. Those gaps must be addressed. Some example of testing gaps in the United States. 57% of adults never have been tested for HIV. 158,000 people living with HIV are unaware of their infection. So in the United States, there's 1.1 million people living with HIV, 13% don't know they're infected. Of those diagnosed with HIV, over 21% had stage 3 disease at the time of diagnosis. Unacceptable to get someone that late. 25% had stage 2 diagnosis. This is something that we must close, that implementation gap. Key challenges to the global HIV community in treatment gaps is the initiation of therapy, adherence to antiviral drugs, and retention and care. Again, getting back to the totality of HIV, Of the 34 million people living with HIV, almost 10 million are not on therapy who should be on therapy. The good news is that 29 million are receiving therapy. The bad news is that almost 10 million are not. If you look at HIV care among people 13 years and older in the United States, for every 100 people living with HIV, 74 received some HIV care, 51 were retained in care, and 65 were virally suppressed. We must do better than that. In addition, we have adherence issues. Only 42% of individuals, almost half of them, had poor adherence. Namely, the days covered with ART were less than 80%. If you look at optimal adherence, namely more than 90% days covered, it is only 38.7%. Again, looking forward, we must do better than that. Let's switch now to prevention. Similar to the toolkit for treatment of HIV, we have an ample prevention toolkit, as shown here, and I'll go through some of them. Importantly is the concept that have now been scientifically proven that treatment is prevention, and treatment can be used as prevention. For it is very clear now that undetectable viral load equals untransmittable, an extremely important advance in the prevention of HIV, as well as the life-saving effect of persons living with HIV. Also, there's pre-exposure prophylaxis. Truvada, now we are 10 years into PrEP, and the results have been striking. If used as directed with optimal, consistent use, Truvada is more than 99% effective in preventing sexual HIV acquisition. Again, getting to implementation gaps, the cumulative number of global PrEP initiations was around 2.8 million. The good news is how much it has progressed, going from the left to the right on the slide from 2016 to 2021. However, even though we have 2.8 million people receiving PrEP, tens of millions of people should be on PrEP. What about the disparity by race and ethnicity? If you look at that, the 25% of the 1.2 million people eligible for PrEP who were prescribed, look at the unequal coverage, with 66% among the white population and only 9 and 16% among Black and Hispanics, respectively. Also, within 6 months of PrEP initiation, only 41% of the users stopped taking it, and 38% had suboptimal adherence. Again, a reminder that as well as we are doing, we must do better. Let's quickly move now to the development and the delivery of new and improved treatment and prevention interventions. First of all, pill taking, as effective as it is, has many barriers to it. Those who are involved in substance abuse, housing insecurity, food insecurity, mental illness, forgetfulness, stigma, pill fatigue, as well as other structural barriers. Now, hearkening back to the medicine cabinet that I showed you for the treatment of persons with HIV, implementation can be augmented by certain new approaches, shown in the yellow box on the right, namely augmenting it with long-acting ART as well as broadly neutralizing antibodies. So let's look at long-acting ART. The FDA has approved the first extended release injectable drugs for people who are living with HIV. We'll get to prevention in a moment. This can be given every 2 months and is highly effective. In fact, as effective, if not more, than daily oral Truvada. We would like to get that, as I'm getting to shortly, better than every 2 months and as spanned as every 6 months. In fact, there were some abstracts in the CROI meeting in February which are highly encouraging, namely a very high rate of viral suppression with the capsid inhibitor lenacapavir that is given twice yearly in both treatment experienced and treatment naive patients, a potentially major breakthrough in treatment. In addition, broadly neutralizing antibodies are now enter the armamentarium of both treatment and prevention. And as most of you know, this is gotten from cloning HIV-specific B cells from individuals who are living with HIV, getting broadly neutralizing antibody and passively transferring it in either treatment or prevention. In other words, the ultimate goal is that you might be able to passively administer a cocktail of broadly neutralizing antibodies, hopefully every 6 months, as opposed to every couple of months, that might actually replace the need of a daily oral ART therapy. And in fact, combination of therapy replacing combination of antibodies prevention therapy has now been shown in a number of studies that have been published from multiple groups throughout the country. And here's an example of one of those studies in which a Kaplan-Meier curve is shown when 2 antibodies directed at different epitopes on the HIV envelope were passively transferred and led to long-term ART-free virological suppression following the time after analytic treatment interruption, with the treatment group in blue and the placebo group in red. Cure, as you know, and I don't have time to go over all the aspects of cure, are aimed at 2 pillars. One is the eradication of the replication competent reservoir, which is aspirational and will be very difficult, not impossible. But another, which is much more feasible, is the sustained virological remission in the absence of ART. Perhaps, as I mentioned a moment ago, with the passive transfer intermittently of broadly neutralizing antibodies.
Someone was detected at your back door eye level.
Slides ago, that one can augment the HIV treatment toolkit. You can do the same with prevention. And again, with the yellow box on the right, you do that with long-acting ART for pre-exposure prophylaxis, as well as broadly neutralizing antibodies. So let's take a look at the promise of long-acting pre-exposure prophylaxis. First, with antivirals. A paradigm very similar to what I showed you a little bit ago, using long-acting for actual treatment. And again, the FDA approved the first injectable treatment for pre-exposure prophylaxis.
Someone was detected at your front door.
Using cabotegravir extended release injectable suspension given every 2 months. And again, the goal being giving it over a much longer duration, hopefully every 6 months or longer. And in fact, the sustained efficacy of long-acting cabotegravir was clearly shown at the AIDS meeting in individuals who were receiving it and had an 89% lower rate of HIV acquisition compared to those receiving daily Truvada. This is a very important advance and will have a major impact on the prevention of HIV in women. And in fact, there are phase 3 trials that are evaluating that same drug, lenacapavir, that can be used for the treatment of persons with HIV, that perhaps a twice-a-year injectable lenacapavir can be used for PrEP. And as you can see, there are a number of studies in both cisgender adolescent girls in Southern Africa, as well as cisgender men, transgender women, transgender men, and gender non-binary people in a number of countries, including the United States, others in South Africa, Peru, and Brazil. Let's quickly go to broadly neutralizing antibodies. There were 2 randomized, very important concept-proving trials that passive transfer of a single monoclonal antibody, VRC01, although the overall protection in the study was not significant, there was good protection against those viruses that were sensitive to the antibody in question, which means that combinations of antibody would be the next step in that. And in fact, we get a lesson from COVID because Evusheld has been shown to be highly effective by almost 83% in reducing the risk of acquisition of COVID at 6 months compared to placebo. We hope that that will be the case with HIV. But what we need to do with HIV is we need to optimize the antibodies in the study I showed you a couple of slides ago by improving breadth, potency, and durability, by understanding what levels of antibody are needed for protection, by understanding the diversity of circulating strains and developing effective combinations, which I believe will be critical, as well as innovative delivery system, either long-acting or vector-based platforms, and of course, always increasing accessibility and affordability. Now, finally, vaccines. We've had 4 decades of vaccine development. The virus was isolated in 1983, proven to be the cause of AIDS in 84. We started early trials in 1987, and efficacy trials began in 1998. Now, we have multiple lessons we've learned over the last 24 years. I'm going to very quickly go through a few slides, and I want you to concentrate on the title of the slide. Beneath the title, I've just shown the published papers that prove the point. But since we don't have time to go through each paper, let's just go through the points that were proven. Back in 2005 and 6, we published that antibodies that bind the envelope but do not neutralize don't protect. That was a phase 3 trial. We tried CD8 T-cell responses in the absence of neutralizing antibodies. Again, it did not protect against infection. The now famous TIE trial, RV144, that induced non-neutralizing antibodies gave a very modest degree of protection, and it was felt that that needed to be validated and corroborated in a higher risk group. Unfortunately, the TIE trial results were not repeated in a population in Southern Africa with a higher HIV incidence prevalence. And in fact, even other vector-based vaccines in similar populations did not introduce neutralizing antibody and did not protect. So as Carl Diefenbach and I wrote in May of 2020 in the Journal of the IAS, we must steadfastly continue to move forward and not be discouraged to address the critical research gaps and unanswered question in vaccine. And the answer, we believe, will be to get the right immunogen, and that will be one or more of the neutralizing epitopes on the HIV envelope shown on the left-hand part of the slide, and let that be the immunogen for the vaccine. We know from experience clinically that when a person is infected with HIV, the virus evolves as shown with the envelope evolution, with the different colored envelopes, and it induces an evolution and a somatic hypermutation leading to affinity maturation of antibodies to ultimately get a broadly neutralizing antibody, which is too late for the patient, but is a big clue for the development of vaccination, where many researchers now are having a sequential stimulation with different envelopes that are pushing along the somatic hypermutation that hopefully will ultimately lead to a broadly neutralizing antibodies. We can do that by perfecting and polishing and maturing the development of hypermutation by a sequential evolution of envelope immunogens. And again, I want to end this discussion by something that has really driven all of the successes in our attempt to get the control and the ending of HIV, and that is to follow the science. But the message that I hope I got through this discussion is that although the science is eloquent and has brought us very far in our battle against this disease, it is critically important that in this scientific advance that we continue to make, that we continue to implement in an optimal way and in a way with a very strong concentration on equity. Thank you.
Great, thank you so much, Dr. Fauci, and to all of our federal colleague speakers for a great start of the 2022 National Ryan White Conference. Please do not forget to fill out the evaluation form for this session. When you navigate to the agenda page of the virtual platform and select the plenary session, you'll find a session evaluation link within the session description. We hope that you will join us for our first concurrent session today, which begins at 4:45 p.m. Eastern Time. The conference will begin again tomorrow morning at 11 a.m. Eastern Time. Today's plenary is adjourned. Thank you so much for your service, and thank you for being here today.